WINCARS Women in Cardiology and Related Sciences is back again with yet it's another academic endeavor, and we know that is none other than the WINCARS e-class, which we hold on the second Thursday of every month. And this time, it is really a privilege for us to have a DM student from AIMS Bathinda, and he is Dr. Vandeep Singh. He's going to present an interesting case for the benefit of all the students. May I request Dr. Soumya, my co-coordinator of the WINCARS meeting, to kindly introduce the faculty of the day.
Good evening, everybody. As Dr. Shiva ma'am had introduced, this is a PG teaching session which we are doing for WINCARS, which we do on second Thursday of every month. Today's case presentation is by Dr. Vandeep Singh, and the examiners are Dr. Prabhavati madam, who is a professor from Jaideva, Dr. Jyotsna madam from NIMS, and Dr. Bhupinder. Because they both said they'll start late, they'll join late, we are starting off with the presentation. Dr. Prabhavati ma'am, thank you for joining us. Over to Dr. Vandeep Singh for the presentation.
Thank you.
Yes, good evening, Dr. Prabhavati, respected Dr. Prabhavati ma'am, and all the other senior faculty. I'm going to present my case now. So I'm presenting a case of a 27-year-old male resident, resident of district Muksar, Punjab. He's a nursing officer by profession and belongs to a modified Kuppuswamy scale of lower middle socioeconomic scale. History is given by patient and his younger brother. Both are reliable informants. He presented with the chief complaints of breathlessness on exertion for 6 years and palpitation for 6 years. The patient was apparently well 6 years ago when he started experiencing breathlessness on exertion, which was insidious in onset and progressive in nature. Initially, the breathlessness occurred while climbing 2 flights of stairs. Over the subsequent 1 year, it gradually progressed, and the patient developed breathlessness even while walking on level ground and doing his household activities. And breathlessness was relieved on rest and was not associated with any cough. No history of any worsening of breathlessness with postural variation. No history of seasonal variation, and not associated with worsening at night after few hours of sleep. And after a year or so of starting symptoms, patient took medical assistance for this and was started on some oral drugs, which led to his increased urine output, following which his symptoms improved. And he has remained largely in NYHA class 2 for the last 5-6 years. And according to the patient, he remains asymptomatic as long as he takes his medications regularly. But when he's non-compliant, he again has increase in breathlessness. Patient also complains of palpitations for last 6 years, which are intermittent in nature. They have sudden onset, and he explains them as pounding sensation in the chest. Initially, he used to get palpitations on exertion only, which were relieved on taking rest. Now, since last 2 years, he's having intermittent episodes even at rest, about 3 to 4 episodes per week, and lasting about 10 to 20 minutes, which gets relieved on its own without any medication. And palpitations are not associated with any loss of consciousness episode. There is no history of chest pain, no history of fever with chills, no history of any blood in sputum, no history of hoarseness of voice, no history of difficulty in swallowing. There is no history of edema feet, abdominal distension, nausea, vomiting, or loss of appetite. There is no history of recurrent chest infections, bluish discoloration of skin or membranes, or squatting episodes in the childhood. In the past history, patient was told to have some valvular heart disease around 5 years ago when he was started on some oral medication, which led to improvement of his symptoms. He was also started on monthly injections in his buttocks, to which he was compliant only for a year or so, and he did not take it after that. And on repeated provocation, a patient also gives history of transient red-colored whole body rash in early childhood when he was around 5 or 6 years. And at that time, he also remembers having ankle joint swelling. No history of repeated throat infections, abnormal body movements, or visible nodules on the body. In the personal history, patient has a mixed diet. There is no history of smoking, no history of alcohol or tobacco intake, no significant drug allergy, no history of diabetes or hypertension. In the family, there are no similar complaints. He's born of a non-consanguineous marriage, and he has a younger brother of 22 years old, not having any current symptoms or any prolonged illness. So
go back to the first slide.
Yes, ma'am.
Next. Yeah. You said dyspnea is class 2.
Yes, ma'am.
What is class 2? NHA class 2?
Ma'am, having dyspnea symptoms on ordinary activities. Ma'am.
What are the symptoms included?
Ma'am, symptoms are dyspnea, palpitations, angina, and fatigability.
So it then progressed to class 3, is it?
Yes, ma'am. Over a course of year or so, and then he sought the treatment.
Okay.
Yes.
No PND orthopnea?
No, ma'am. No specifically asked. No history of PND and orthopnea.
Palpitation, you think it is volume-only palpitation or arrhythmic palpitation?
Ma'am, initially, yes, ma'am. Initially, ma'am, the way he says, whenever he got exerted due to some heavy work, only then he used to get palpitations. So those have to be volume overload status. But now, even at rest, he has some tachycardia palpitation episodes. They have pounding sensation in the chest. So now maybe he has some arrhythmia developing during the course of the disease, progression of the disease.
What kind of arrhythmia?
Yes, ma'am. The way it gets sudden in onset and gets lived on its own, I'm thinking of some supraventricular tachycardia or atrial fibrillation.
Does he say it is regular, irregular? Is he able to differentiate?
Ma'am, he's not able to differentiate.
Okay. What next, you said? Next symptom? What?
He does not have any other symptom. No chest pain. No syncope.
Okay. Next slide. You said some whole body rash. What do you think that was?
Ma'am, the way he describes it, it was non-pruritic and whole on the whole body, mainly on the trunk, and maybe some acute rheumatic fever presentation, erythema marginatum, and would be that. But since mother was not there, only his younger brother and he told the history. They were not so sure
Where
about
do you
that.
find that normally? How common is it?
Ma'am, erythema marginatum is very less common, in less than 5%. So
You said nodules. Will the
yes.
patient tell that they have nodules?
Yes, ma'am. I asked him if he had any bumps or lumps on his elbows. He said he does not remember.
Painless?
Ma'am, they're painless. The what I
You will have to look for them.
ma'am, we
Nodule.
have to look on the occiput. We can see on the extensor surfaces of arms. We can see them on chins.
These erythema marginatum and nodules, are they associated with carditis or?
Yes, ma'am. They're both are associated with carditis.
They're always associated.
Yes, ma'am. Always associated. Yes, ma'am.
Okay. How often these streptococcal sore throats are asymptomatic or mildly symptomatic so that you will not be able to tell? You said there is no history of repeated throat infections.
Ma'am, around 50% of the patients do not recall any history of acute rheumatic fever.
No, not rheumatic fever, throat infections. How often they are asymptomatic or mildly symptomatic so that they'll not be able to?
Yes, ma'am. Symptomatic.
Yeah, 1/3 to 2/3 of them may not have symptoms or mild symptoms.
Okay, 1/3. Okay.
This penicillin prophylaxis, is it monthly injection or what is the recommendation?
Ma'am, recommendation is 21 days because 21 days has a MIC. They achieved the inhibitory dose in all the patients who were on 21 days. But if given as 4 week, 1/3 had a lower threshold level, 1/3 had equal level. So it is always recommended 21 days. all of them achieved MIC.
What are the predictors of chronic rheumatic heart disease when they get acute rheumatic fever?
Yes, ma'am. Recurrent infections is a feature, and severe, if we have acute rheumatic fever with the carditis, then 66% of them develop. If without overall, with overall, it is 1/3, 33%.
What are the predictors they asked?
Yes, ma'am, severe carditis in that acute rheumatic fever episode, and repeated episodes of ARF, ma'am.
Anything else? Younger age of onset.
Younger age of onset.
Days.
Okay.
Suppose you give regular penicillin prophylaxis.
Yes, ma'am.
And patient had acute rheumatic fever with mitral regurgitation. How likely that, how often they can recover?
Ma'am, there is decrease of 90% of the development of the chronicity of the acute rheumatic fever if they're on penicillin.
Any study you are aware?
I cannot quote the study.
What about AR?
Yes, ma'am.
AR. MR is more likely to disappear or AR?
Ma'am, AR is more likely to disappear.
No, it's MR. The Tompkins study, 70% of MR murmur disappeared, whereas AR less likely to disappear.
Okay.
It's all in the pre-echo era, so only by auscultation. Okay. He was still on diuretic, is it? You can
yes,
say.
Ma'am. Yes, ma'am. Yes, ma'am. Yes,
and he's on diuretic. Yeah. Why did he stop? Why do they generally stop?
He did not like monthly IM injections on his buttocks, so he was not compliant.
How to improve the compliance?
You can counsel them that it is very important.
No, it's because of the pain.
You can do drug testing before giving we can give a test dose.
For what?
To prevent any allergic reaction at the site.
What is the incidence of allergic reactions and anaphylaxis with penicillin prophylaxis?
It is very less than 5%.
It's not 5%. Okay. So summarize your history and what are the
yes, ma'am. So, ma'am, I have a 27-year-old male patient of lower socioeconomic class, and with a progressive history of dyspnea on exertion and palpitations for last 6 years. So I'm most likely suspecting CVS system to be involved, in which left side of the heart is involved, and most likely valvular pathology.
Which one?
Ma'am, I'm based on the history, I have suspicion of mitral valve involvement.
MS or MR?
Ma'am, I'm more suspicious of mitral regurgitation.
Why?
Ma'am, during the last 6 years, he has not given any history of PND or orthopnea. He's more like exertional dyspnea and associated palpitations with more of exertion. So volume overload status is what I'm more inclined towards.
What is the early symptom in MR in general?
In general, it is dyspnea on exertion and easy fatigability.
Why fatigue? Fatigue is an early symptom. Dyspnea comes later in the natural history, usually.
Yes, ma'am. Fatigue, due to low cardiac output, we have a LV inflow issue. So,
actually, when you have a more prolonged dyspnea and exertion of the 6 years, you should think of the mitral stenosis first than the MR. That's what madam is trying to say to you. And usually the dyspnea then occurs in the later stages of the MR. Either the LV dysfunction has to occur, or the PAH has to develop, or the patient should have the associated mitral stenosis. So, pure MR producing a dyspnea is not an early symptom.
Right.
And
Okay.
if at all, if it is an MS, what is the cause for the palpitation?
Ma'am,
That you are saying exertional. So tell about the exertional causes only.
yes, ma'am. Exertional causes, ma'am, more of related with the volume overload, but
Talking about MS. Is that
MS,
an exertional precipitating factor for the mitral stenosis and related palpitation?
yes, ma'am, tachycardia can precipitate MS. So sinus tachycardia can be there, sir. And
What will
increase.
happen if the AF is a controlled ventricular rate, and what will happen with the uncontrolled ventricular rate?
Ma'am, in uncontrolled ventricular rate, there will be increase in the gradient across diastolic gradient between LA and LV diastolic gradient.
What will happen in the AF? Whenever they exert, the rate will increase. So
rate will increase.
The intensity getting controlled may becomes a manifest when they do the exertion. So always we classically talk about the AF is irregular rhythm, so the patient can perceive very well. That is not true always. Like he may not able to perceive. If it is happens for the first time, he will perceive, but it is a persistent for a long time. He doesn't perceive as an irregular beat. So at the time during exertion, that will causes it. And what are the other causes of the palpitation in the MS? Because you are not considering MS at all. That's the reason why I have to concentrate. Because incidence wise and even natural history is suggestive more of a MS than an MR.
Okay.
That's the reason why I'm asking so many questions on the MS.
Why are you not considering, as Madam said, why are you not considering mitral stenosis?
Yes, ma'am. MS should also be considered here. I'm wrong in that.
Why heart rate increases on exertion in atrial fibrillation?
Due to the requirement increased cardiac output required.
No, what decides the ventricular? What is the atrial rate in atrial fibrillation?
More than 300 to 600.
350 to 600. So what decides the ventricular rate? AV conduction.
AV conduction.
So AV conduction increases because of increased sympathetic activity.
What ma'am is trying to tell that there are so many clinically there are so many things which will be possible. You cannot just say as regurgitant lesion as a dominant lesion. Even as ma'am is trying to tell that the control rate may not be perceived as palpitation, even if atrial fibrillation is there at rest. And if during exertion, patient will feel that increased ventricular rate in the presence of atrial fibrillation as exertional palpitation. So it may not be true. So you cannot be so rigid with a particular diagnosis at the history. So you have to entertain and all the more important, as highlighted, MR will just be presenting as fatigue until unless there is LV dysfunction or there is some precipitating factor to it. And MS can just present with the progressive as a progressive illness as anytime having atrial fibrillation or palpitation or progressive dyspnea, orthopnea, PNDs and all. So even as per your history with the progression of the disease, dyspnea as a dominant symptom, MS will always be, even by epidemiology or by the natural history or by, so you can stick to a mixed mitral valve disease if you want to entertain, and rather than like that, maybe dominant mitral stenosis associated. So mixed mitral valve disease, saying that also suffice rather than just committing that only and the only recurgitant lesion as the differential.
So tell your possibilities.
Yes, ma'am. I'm keeping rheumatic heart disease first as my diagnosis. Then it could be, ma'am, mitral valve prolapse.
In the rheumatic, you are already considered all the conditions and you are going to the other etiology.
Yes, ma'am. Based on the history, aortic seems less involved because in the aortic, I would keep AR as more than the AS. AS doesn't seem like AS from the history only.
What is sign qua non sign to say that left heart is involved?
That is orthopnea PND should be
So
there.
that is not there. So why you
Yes, ma'am.
want to stick on to left heart only then? You can have exertional breathlessness in right heart along with the palpitations. Even though it is a pure isolated tricuspid stenosis or regurgitation, in a rheumatic is less, but it can be predominant feature in that. But usually by the 6 years, usually right heart failure symptoms will manifest also clinically, which is not there. So
Yes.
you consider them.
Yes.
That's what I meant it. You have to consider
Okay.
to prove that, yes, this is comes last. It's like that.
Okay. Yes.
Okay, now you are from the rheumatic, you are going to mitral valve prolapse.
Yes, ma'am.
So what is the features in favor for the mitral valve prolapse and what is in against? And mitral valve prolapse is not a diagnosis. With some lesion you wanted to say it. Are there simple mitral valve prolapse will complain all these things?
No, ma'am. In this young age, it will not. When the valve gets degenerative
Say
in the
it,
late
at least
40s.
you complete the sentence. What you meant it to explain all your symptoms.
So apart from valvular disease, I mean, you just want to focus on valve or any other
Sir,
pathophysiological?
we can have a dilated cardiomyopathy as a differential also involving the left system. So it will present as easy fatigability and exertional dyspnea initially, and palpitations are associated with it due to volume overload on exertion. But patient does not have any family history
Okay,
or
all the causes of all the types of the cardiomyopathy, what you considered with this history? Only palpitation and exertional breathlessness. Age is 27. Huh? How much you
yes,
said?
yes, ma'am.
So which cardiomyopathy you considered as the first one? If the patient has a PND episodes and sometimes epidural because of biventricular involvement, DCM could be the first. You wanted to take a DCM as the first in this?
Yes, ma'am. Restricted cardiomyopathy could also be another plausible differential.
Which one? I could not hear.
Restrictive cardiomyopathy in a young patient.
If it is the right side predominant, probably you should bring the restrictive as the first. What is the leftover one? Very frequent.
Hypertrophy.
So the long-standing, whenever there is symptoms, you have to consider the hypertrophic cardiomyopathy, even though varied age groups are noted associated with the HOCM. Okay.
Yes, ma'am. Yes. Okay.
Yeah, please go ahead. Madam, you wanted, sir, you wanted to ask any other questions at the history level?
He was diagnosed to have heart disease, you said, no? Was he advised any treatment at that time other than
he was
medications?
Ma'am, he was told to get serial echoes done, and maybe later on he will require valve surgery. That was what he was told at that time.
So it's likely to be valvular heart disease then.
Ma'am, according to patient, yes.
Okay. We'll go ahead with the examination.
Yes.
Anything, Bhupender, you want to ask anything?
No, ma'am. It's fine, ma'am. We can carry on with the
Okay.
exam.
25 minutes. Yeah.
So patient is calm, conscious, and well-oriented to time, place, and person with moderately built and moderately nourished. His height is 174 and weight centimeter and weight is 68. So BMI comes out to 22.4 and arm span is 172 centimeter. So upper segment and lower segment ratio is around 0.95. He does not have any history of pallor. There's no pallor, there's no icterus, clubbing, cyanosis, lymphedema, lymphadenopathy or edema. His BP is 126/58 in right upper limb, brachial artery, 128/16 left upper limb, and around 166/72 in both lower limb popliteal arteries. His pulse is 78 per minute. It is regular, bounding. high volume pulse, and difference in character. It is bilaterally symmetrical without any radial or radiofemoral delay, with normal condition of the arterial wall. And all the peripheral pulses are present. Waterhammer pulse is also present. JVP is normal with normal X and Y descents. His respiration is 16 per minute, regular and abdominothoracic. Patient is afebrile and maintaining 100% saturation at room air. Hair color are normal. He has symmetrical faces with good oral hygiene maintained. No thyroid swelling. Nails appear normal. No deformed joints. No palpable nodules on the body. In the peripheral signs, he has a Corrigan's pulse. Hill's sign is positive, and pistol shots of Probe sign is also positive. So in CVS examination, the chest is normal shaped, bilateral symmetrical with transverse diameter more than AP diameter.
For the positive findings in the inspection, and whenever you talk about the hill sign, you should tell how many millimeters. That is much more than
Yes.
important. Of course,
around 60 mm. Hill sign being positive, he has 60 mm more blood pressure in the popliteal arteries than brachial artery.
Why
And
it is important to mention about it?
Ma'am, it is a very specific sign for aortic regurgitation. Whenever we have more than 20 mm more blood pressure in the...
For the AR? It can't
Yes,
have another aortic runoffs? Why you are saying AR?
It is a...
Any aortic runoff can have it, no?
Yes, ma'am. High cardiac output states also, it can be positive. Yes, ma'am.
What is the controversy about Hill sign? Is it fact or artifact?
Mostly it is augmentation of the wave propagation. So it's more of an artifact.
Sphygmomanometer artifact, no? They have measured blood pressure in the upper limb, lower limb, found to be same. Okay.
Then
it is still useful to assess severity. Fine.
Please, can you go for presentation mode? It is in PPT mode.
Yes, ma'am.
Yeah, good. Please go ahead.
Yes, ma'am. We need to have proper cuff size to measure the BP in the lower limbs. Then only we can reliably say.
How do you measure the lower limb BP?
Ma'am, we put the patient in prone position and I made it in popliteal arteries. I took a bigger BP cuff.
You can use same cuff on the calf and palpate
cuff and do DPA. Yes, ma'am. Yes, ma'am. You can also do that.
Okay.
In inspection, chest is normally shaped bilateral symmetrical with transverse diameter more than AP diameter. Precordial shape is normal. Apical impulse is seen in the sixth left intercostal space, lateral to the mid-clavicular line. And the suprasternal pulsations are seen. There are no epigastric pulsations, no scars, no sinuses or dilated veins. In palpation, apex beat is palpable in the sixth intercostal space, 13 centimeters from the mid-sternal line. It is localized and hyperdynamic in nature. There is no parasternal heave. There is no thrill in precordium. Bilateral carotid arteries are palpable and equal with carotid thrill is present. P2 is not palpable. In the percussion, upper border of liver dullness is present in the right fifth intercostal space. Left heart border corresponds to the down and out apex. Right heart border is substernal, and left second intercostal space is resonant. In the auscultation, S1 is soft, S2 is normal split with the soft A2 and normal P2 with normal variation with respiration. There is no S3, S4, opening snap, click or rub. There is a pan-systolic high-pitched blowing murmur of grade 3 intensity. Grade 3 intensity, best heard at apex with the diaphragm of the stethoscope in left lateral decubitus position, radiating to axilla. And there is also a low-pitched rumbling mid-diastolic murmur of grade 2 in intensity, best heard at apex with the bell of the stethoscope in left lateral decubitus position. It does not have any opening snap or pre-systolic accentuation. Then a high-pitched blowing early diastolic decrescendo murmur of grade 3 intensity. In third left intercostal space, best heard with the diaphragm of the stethoscope in leaning forward and in end expiration. Also a harsh mixed frequency, early peaking ejection systolic murmur of grade 3 intensity is heard best in the aortic area with the diaphragm of the stethoscope in the same leaning forward position, and it is conducted to bilateral carotids.
What is the length of this idiom?
Ma'am, it is a long idiom. It's a long idiom.
Not mentioned that.
Yes.
The gradings are not done nowadays?
Yes, ma'am.
Is the gradings are not done like a 3/4?
3/6, ma'am. 3/6.
But you have never mentioned anywhere. So I thought probably it is removed in the recent clinics.
No, sorry. It's 3/6.
You said grade 3.
Yes,
ESM.
ma'am. Yes, ma'am. ESM is also grade 3.
You should also mention whether it is long, late peaking.
Ma'am, it is early peaking. The ESM is early peaking, ma'am.
Early peaking, okay.
Yes, ma'am. It is not late peaking.
Is it longer?
No, ma'am. ESM is shorter, early peaking. EDM is longer, long.
So you think it is organic or?
Ma'am, I think it is a floor-related murmur of the aortic regurgitation.
What is more important? The length of the murmur is important in which type of murmurs? The diastolic or systolic murmurs?
Ma'am, sir, in diastolic murmurs, the length is more important, which tells us the gradient. And in systolic, like ejection systolic murmur, it is the where it peaks is more important than the length of the murmur.
No, in AS length is also important. In MR length is not important.
Okay.
MR has to be pansystolic. It cannot be.
Pansystolic.
And you said S2 split is heard, A2 is soft, and
Yes.
P2 is normal intensity.
Yes, ma'am.
How could you say that A2 is soft?
Ma'am, the initial portion of the split is very soft. Ma'am, P2 is well heard in the pulmonic area.
No, what I mean to say it is, if the PAH is there, then P2 load may increase. So if you are comparing with the P2, your A2 component will be the softer. So
Yes.
I want to know how you could say that. That's what I wanted to
Yes, ma'am.
explain.
We say P2 is loud when it is heard with equal intensity at the apex as the base. So it was not like that.
Okay, so that is the intensity of herding of the P2 to the other areas will give you
Yes,
whether you can compare with an A2 or a P2. That is okay. If the MR murmur itself can cause the softening of A2?
Yes, ma'am.
How do you explain the pansystolic murmur on the left side and the right side?
Left side.
That explains softness of A2. It need not to be an aortic disease which is responsible for the soft A2. It is extends the MR murmur on the left side. It extends up to the and sometimes even it's overlaps
Yes.
onto
Overlaps the A2.
So then it is known to produce. Or otherwise, your description is giving an impression that it is an aortic disease is also is a predominant, which can be explained with an MR itself. That's what I meant it.
Okay.
But if other signs are the more predominant, yes, you can substantiate it.
Okay.
And your murmur description should be the much more better than at present what you have done it. Like you are not included
Grades. 3/6.
And exercise related, posture related. It is worth mentioning all of them.
Okay. We have to mention it, ma'am. If it is well heard also, then dynamic, we have to mention upfront only.
Of course. HOCM is well heard. You will have the 4/4, 4/6 or 5/6 also. But still, you will have a variation. No? And this tricuspid or the mitral, one of the important thing is other than the site, is the respiratory variation.
Yes, ma'am. Okay.
So all 6 components for the murmur, it should come like a flow.
This
Uh,
MD with the apex, what do you think is the cause? Is it oxygen flint or increased flow across the mitral valve due to MR, or what is the cause of this MDM?
Ma'am, I think it's increased flow across the mitral valve due to severe MR. This is flow murmur of MR.
How did you decide that it is not oxygen flint?
Like there's a significant mitral regurgitation, and both of oxygen flint and flow murmur of MR would not have a pre-systolic accentuation and opening stab, and my murmur does not have these two. But since mitral valve is involved, is more likely significantly mitral regurgitation is there.
Finished your findings, or you're done with that, or anything more?
No, ma'am, done.
What's your diagnosis?
So, ma'am, my diagnosis, we have a 27-year-old male who's having an acquired valvular heart disease of rheumatic etiology in the form of severe mitral regurgitation and severe aortic regurgitation with no evidence of pulmonary hypertension. Patient is in sinus rhythm without any evidence of active rheumatic disease or infective endocarditis or congestive cardiac failure on any thromboembolic phenomena. Patient is currently in NYHA class 2 on diuretic therapy.
What are the criteria to say that it is severe MR?
Yes, sir. So the patient needs to be symptomatic first, and then clinically, if we have a MDM of severe mitral regurgitation, we consider having significant mitral regurgitation. And
all severe
S3,
MR need not be symptomatic.
okay.
What are the criteria to say severe MR, and what all are applicable in this patient?
Ma'am, we need S3 is also a hard marker of severe mitral regurgitation and MDM. S3 I could not appreciate in my patient.
Actually, S3 is not always the severity. Even in the moderate MR also, you can have the S3. But usually from the moderate onwards, it is present. If it is an absent, then you have to think for a second time why it is an absent. Is that mitral stenosis is a predominant? What is preventing to produce it?
Okay.
And you should go out of the way to see for those signs once you wanted to commit as a severe MR. Presence of an S3.
So some of the findings which will suggest us as severe MR is the flow murmur across the mitral valve you told, and presence of S3 as ma'am has told. And then you can have supportive features which will suggest you that this is severe MR. So tell about those supportive features
yes,
also.
sir. Supportive features will be, sir, apex will be displaced down and out. It will be a hyperdynamic LV type of apex.
That can happen in AR also.
Yes,
you said AR also severe.
Yes, ma'am. In the mixed valvular conditions, it is
Difficult.
both have recurrent lesion. Both will produce a down and out apex.
So you can answer like, and suppose it's so theoretically, if the question goes like that, you can answer in the presence of isolated mitral regurgitation. These are the possible things. And then pertaining to your case, you can further elaborate that these are the possible, why I've kept the possibility of severe MR. So that's how you have to tell.
Suppose the patient has the heaving apex. You wanted to give a diagnosis completely?
Yes, ma'am. If we have a heaving apex, then a regurgitant lesion can have a heaving apex once the LV fails. But then heaving apex along with my narrow pulse pressure and systolic BP decapitation, then I will consider aortic stenosis as the more predominant lesion in the aortic. But here it is not there. So,
is there any systolic decapitation?
ma'am,
No.
when the
Here systolic BP is not 158, you said?
Yes, ma'am, it is 120/60. Like
Yeah,
20
what
or 6.
madam, what he's saying is correct. If your AR is significant, you should have a systolic hypertension. So not having
Yes.
that itself is a decapitation. I'm not seeing any answers from the students, as if the only Mr. Singh is interested in this case.
We have
Please.
I think we
we
should
have
put
put it
more.
in the chat box, ma'am, but somehow nobody is answering.
I think we can pinpoint the name
There is
and
a
then
comment
subsequently
just
pass on
now.
the
There is a
question.
comment
That would
from
be a better way.
Hardik Jain. Austin Flint murmur would have aggravated with sustained hand grip and not seen with flow murmur of MR.
Yeah,
Yeah.
that's true. And that's the reason exercise related one, you have to mention it every time with the
Once
respiration.
you do it, yeah. So once you do it as ma'am, that's why those are the reasons why the statements of all the murmur should be correctly said. Then only you'll be able to answer.
Yes, but and would not sustained hand grip also increase the flow murmur of MR, because MR also gets aggravated by increasing afterload. So I searched very vastly, but I could not find accurate differentiation between flow murmur of MDM versus Austin Flint.
Actually, the major differences are mainly depends upon the severity of the AR signs and the severity of the MR signs, whatever you have it. But the
Okay.
mechanisms are then entirely different. Like a aortic regurgitant jet strides through the mitral valve
Yes.
and causes the partial closure of the mitral valve and produces the mid-diastolic murmur. Whereas this is then actually increase the gradient of the left atrium to the left ventricle because of the mitral stenosis, that is producing the MDM. So the pitch will vary. It is usually the low pitched one mid to the late diastolic. It is mid to late diastolic. Whereas this Austin Flint murmur. And most of these is a mid diastolic murmur if it is an MDM, unless they have a presystolic accentuation. And usually the sinus rhythm is much more frequent in the case of a in the case of an aortic, whereas it is a more, AF is more frequent with the MS. So that's why we have to rely upon exact murmur description, except the pitch and the location, either mid or late. Except these two, all others mainly depends upon the severity of the MR and AR.
Okay.
The hand grip, why it is the major, why it has an effect is hand grip increases the peripheral vascular resistance. So because of the increase in the peripheral vascular resistance, aortic regurgitation increases. But in the mitral valve is in the case that is not going to be the increase, so it doesn't alter it. But all these are the subtles, but it is worth mentioning it. Unless you practice, it won't come as a routine for you. Because in our olden days, we used to concentrate more on the clinics. Nowadays, you concentrate more on the echo. That's why gradually the clinical science waves off and we may not able to pick them up.
I think we'll have to move on to investigation. They
Correct.
said by 8:15 we'll have to start.
Yes. So this is the ECG of our case, 27-year-old gentleman.
Put it on this mode. Change the mode.
Read the ECG. Positive.
Yes. So it's a surface electrode ECG, 12-way surface electrode ECG. It is, the rhythm is a sinus. We have a rate around 70 beats per minute. The axis is normal. Then we
what
have
is axis? Approximate axis.
Approximate axis, ma'am, around 0.
0.
30.
Go ahead.
We have signs of left atrial enlargement, as we can see in the P mitral, left atrial enlargement sign. Then we have signs of left ventricular hypertrophy. Then volume overload status is there because we have deep Q waves in V5, V6 with tall T waves. So volume overload state. is there.
The left atrial enlargement, LVH with volume overload.
Yes.
Which can occur in volume overload can occur in both MR, AR, right?
Yes. Yes, ma'am.
Is there any way to differentiate whether the LVH is because of MR or AR?
Because in pure isolated AR, the left atrial enlargement will not be that much as in with the MR. So as we can also see, there is mitral left atrial enlargement also. So
Any other?
both are.
Anyway, go and read. Okay, go to X-ray. Madam, you want to ask anything?
This left atrial size, MS has a bigger size or the MR will have a bigger size, usually, to the same degree of the stenosis or regurgitation?
MR will have a bigger LA size.
Okay, good. Please go ahead.
So this is the left side, we have a PA view of the chest, and on the right side, we have a lateral view. So as on the left side, we have a PA view, and we have a slightly overexposed image. You can see the spinous process easily. This slightly rotated. Then the bony structure is normal. Then the airway is normal. We have in the cardiac, we have increased cardiothoracic ratio.
Chamber enlargements, you go and say it. Which chambers are already enlarged?
Ma'am, left ventricle is enlarged, and left atrium is enlarged. Because
what are the criteria seen here for left atrial enlargement?
Ma'am, it is the chamber which is crossing the spine is left atrial here.
You have both.
And we have a splaying, ma'am, we have splaying of carina is there.
Yeah.
We have increased angle there. Then
How much angle is there?
Sir, about 90 degree is there, and so here it is
more than
around 110 to 120.
Is there double density?
Yes. That is more prominently seen, double density.
Yes, ma'am, double density sign is also there.
Which is substantiated by the lateral view. What is that?
Yes, ma'am.
What is that showing?
The retrosternal space in the X-ray is obliterated.
Retrosternal is not by the left atrium. Posterior.
Posterior, yes. Posterior L is the posterior structure, most posterior structure. So posterior enlargement we can see.
Retrosternal space is occupied by which chamber?
Yes, ma'am.
Retrosternal space, you said, no?
Yes, ma'am.
What is sternal compact?
That is occupied by right ventricle.
Correct.
So some degree of right ventricular enlargement is there.
What is striking? You have a severe AR. What do you expect on aortic shadow?
I expect a prominent aortic knuckle.
Yeah. Knuckle. You will have the ascending aorta more prominent. Diffuse aortic dilatation. Ascending aorta, arch, as well as the descending. So, but here the hardly ascending aorta, you are able to see it there. And of course, knuckle and descending aorta seen, but that may be because of over-penetrated.
Yes.
And even in the lateral view, you are not able to see the ascending aorta prominence. That is strikingly absent in this. Okay.
What is the pulmonary vascularity? Is there any hypertension?
Yes, we have some cephalization of veins is there.
Of course, it's an over-penetrated view.
Yes, ma'am. And we have yes, ma'am. That there's no curly lines, no evidence of for more grade of pulmonary venous hypertension.
So how do you grade pulmonary venous hypertension?
Yes, we have from 13 to 18 of Hg. We can have cephalization. From 18 to 25, we have curly B lines. And then more than 25, we have bat wing appearance. And then
This is applicable in chronic pulmonary venous hypertension or acute?
ma'am, chronic.
Beyond 25, alveolar edema.
Yes, ma'am.
Is it acute or chronic?
Ma'am, chronic.
So does this X-ray fits into suppose on after clinical examination you have two regurgitant lesion. What do you think the more dominant lesion looking at the X-ray?
Sir, mitral regurgitation appears to be the more dominant. Yes.
Why?
Because we have a huge LA dilation that is not seen in more predominant AR lesions. So, and MR can also produce this much cardiomegaly. So, both LA and LV are largely related. So, MR, I think, more from judging from just the X-ray.
Shall we go to echo?
Yes. So, I have a transthoracic echocardiographic parasternal view, which is showing LA dilation.
Parasternal long axis view.
Long axis view, which is showing LA dilation. And this somewhat thickened aortic valve and thickened mitral valve. Posterior PML has restricted movement, and LV contractility is good, judging from this plaques. And if we put color Doppler on the aortic valve, we can see a
No, even before putting the color also,
yes,
the approximation, the
approximate
of the aorta,
yes, ma'am.
aortic valve
It
is
is
not there. So
loss of coaptation is there in the aortic leaflets.
Can see a big non-coaptation.
Yes, ma'am.
Yeah, go ahead.
And we have a large mitral regurgitation.
Is the word large mitral regurgitation?
Swale mitral regurgitation.
What are you mentioning?
Ma'am, the PML AML difference.
Leaflet separation.
Leaflet separation. Yes, ma'am.
What is the value to say the significant MS?
Ma'am, less than 0.8. We say it is.
Okay.
And we have orifice area of mitral valve. Then we have gradients across aortic valve, forward gradients.
How much it is?
So, ma'am, Pmax is 3.7 and mean is 33.
Is it functional or there is any organic aortic stenosis?
Ma'am, it looks like functional only due to increased blood flow across the valve.
And you have seen non-coaptation so severe. Do you expect aortic stenosis in such a non-coaptation?
No, ma'am. Only functional is there. So we have polodiastolic flow reversal. Area also is more than 1. That's
LV function is normal?
ma'am, from the short axis, it is depressed. Mild LV dysfunction is there.
EF is looked for.
What are the chamber dimensions?
Sir, LV is around 62 diastolic and systolic is around 48.
What are the severity criteria of mitral regurgitation on echocardiography?
Yes, sir. So we can do it with the vena contracta. If we have vena contracta more than 0.7, or we have EROA of more than 0.4, and if the regurgitant volume is more than 60 ml, or the regurgitant fraction is more than 50%, then these are the values we can say MR is more severe.
Any color Doppler criteria?
For regurgitant fraction to calculate here, you have an AR and an MR. So how do you calculate the regurgitant fraction here? You said more than 30 ml and everything. How can you do it when the two regurgitant lesions are there? Is that possible or not possible?
Not, ma'am, because we have a stroke volume is divided between forward stroke volume and
What is the effect of MR on AR and AR on MR?
ma'am, if we have a proximal MR, then peripheral signs of AR can diminish because we have a low pressure zone of left atrium also, so that large stroke volume also goes backwards into the LA. So that increased volume of
The
AR,
forward stroke volume is reduced.
for effective forward stroke volume is reduced, ma'am. And but AR can aggravate MR, ma'am, because we have even larger diastolic volume that can enter LA during its regurgitant phase.
So what do you want to do?
Ma'am, we can go ahead with the, as patient is symptomatic, and we can go ahead with the double valve replacement.
Can they repair the mitral valve? Rheumatic?
Yes, ma'am. If the patient is young, the valve is non-calcific and pliable valve, then mitral valve repair is always preferred over replacement if we can preserve its the chordae and papillary muscles.
Is it a norm? Is there any difference between rheumatic etiology repair versus non-rheumatic etiology repair?
Yes, ma'am. So rheumatic etiology, usually we have calcified leaflets, degenerated leaflets. So
Calcification
mostly
is one aspect. It's not degenerated disease. It's not a degenerative disease. Rheumatic heart
calcified.
disease is not a degenerative disease.
Yes, sir. In other causes, like we can go for a transcatheter approach. You can have.
No, that's
What are the indications for mitral valve surgery in MR?
Yes, ma'am, the patient, symptomatic patient. Yes, ma'am, in MR, ma'am?
Yes, MR.
Yes, ma'am. If the patient is symptomatic and that symptoms are attributed to MR, then we need to go ahead with that. And if the asymptomatic patient of having severe MR, we can see the ejection fraction. If it is less than 60, then it is also class 1. If the LV and systolic volume is more than 40, then also it's a class. Systolic dimension, ma'am. Dimension in the plaques, then also class 1 indication.
Any other class 1 indication in the recent European guideline?
Ma'am, development of atrial fibrillation.
For AR, what are the indications?
Yes, ma'am. For AR, first most, if the patient is symptomatic, and if asymptomatic severe AR is there, then we can go with the ejection fraction less than 50% or the LV and systolic dimension more than 50. Then we can mostly follow 50-50 rule in the aortic and 60-40 rule in the mitral for asymptomatic to get treatment.
Is it 55 now? Ejection fraction?
I'm aware of 50. Okay, it's 55.
Dr. Soumya, is it time now? 8:32.
I mean, you can ask about the management and wrap up now.
Yeah. Madam, you want to ask anything?
And just to want to say that is the TMVR is done or edge to repair is done in the rheumatic?
Yes, ma'am. In rheumatic, it is less commonly done because valve is mostly calcific and the old age patient undergo. But
I wanted to say you, unless the examiner asks whether this is done, don't start with this. That's what I
okay.
wanted to say. Okay. Thank
Okay,
you.
ma'am. Okay.
Thank you.
Okay.
Well done. You had
Thank
done
you so much, ma'am. Thank
almost
you for your insights, ma'am. They were very helpful. Thank you. I will keep in mind and improve on it, ma'am.
answered all the questions. I'm very, very happy.
Thank you. Thank you, ma'am. Thank you.
I think
Okay.
I should congratulate Bhupendra Singh sir because he's training you so well.
Thank you, ma'am.
Thank
We are
you,
still
Thank you,
Bhupendra.
sir.
learning.
Thank
We
you.
are a new
Thank you.
institute and we are still learning.
Yeah,
Yeah, we keep
this
learning
type of
together.
the teachings will help you, sir, actually. Multiple
I think
people.
getting congratulations from Dr. Jyotsna ma'am is so I think it's been a great learning session. We all enjoyed, and it's always great to learn from masters who are always around. I would like to extend my hearty thanks to the great faculty of the day who have imparted us their wisdom. Dr. Jyotsna Madhuri ma'am, Dr. Prabhavati ma'am, and of course, Dr. Bhupinder, who have, guided not just Dr. Vandeep, but also all the attendees who have joined and participated in the session. And of course, a great congratulations to you, Dr. Vandeep. And we hope that you keep learning and
Yes.
you're building up on your skills under the guidance of your mentors.
Yes,
And
ma'am. Thank you.
thank you, one and all. And Dr. Soumya, my coordinator, is also around. Maybe we can have a word from you before we conclude this session. Soumya, are you there?
Yes, ma'am. So, in conclusion, again, I thank everybody, all the teachers who have taken their time and they've come and asked questions to the postgraduates. I would love to see more postgraduates attending the session and answering in the chat box rather than only one person getting grilled. So this happens every second Thursday of month. So all the postgraduates, please be on the watch out. We'll be circulating the flyers so that more and more people can learn from nationwide faculty. Thank you, everybody. Good night.